Yeah. All right, good afternoon, everybody. Thank you so much for joining us this afternoon for our talk looking at and examining the intersection of AI and human work. And so what we really wanted to get started with, and we're going to take maybe about 2 minutes, if you use this QR code and or you can type in this link at the bottom. We wanted to get some of your thoughts when considering emergency medicine and artificial intelligence. What thoughts first come to mind? So we'll give maybe 2 minutes to have people fill this out, and you'll see that this is a Padlet, and we will go through some of the results in a second.
And our goal is that this will be a pretty interactive session, and hopefully as we're talking, giving a little bit of intro to some of the big topics. You guys are coming up with questions. There'll be a QR code up the whole time, and ready to engage when we get into the second half, which is really the open forum discussion that we can try to navigate these issues together.
Very snarky comment. I'm gonna hold it.
Well, save it for the open.
We do have a question and answer section just for that. So. All right, give everybody about another minute or so. Can you see? Mm-hmm. Yeah.
I know, that's the word. Yeah, I know. Wow, somebody's gonna make a new post. I know.
Alrighty, so to kick things off, just to summarize a little bit what we're seeing here on this Padlet. So it seems like a lot of people are recognizing its ability to help, picking up things people missed, being able to narrow and expand differentials appropriately, increasing efficiency, and thinking, frameworks of thinking, useful for charting. Some people are pointing out maybe the potential for bias, so maybe some of the negatives. Really appreciate this one, deployment chaos, which I think is a sentiment many people feel as this is becoming more and more popular. Discharge planning, make robots do menial tasks for me. That's great. I think that's a wonderful way to think about a way to implement it. And note writing. And so this is a really great way for us to start at least thinking about ways in which we are going to be using artificial intelligence here in emergency medicine. And really what our goal in this talk today is to start thinking about the intersection of emergency medicine and artificial intelligence, specifically with us as providers. And how do we really consider this interaction that we have in the development of something like an augmented intelligence? And so we also have this QR code here. It's going to be throughout our slide deck. But as we go through the talk, please share your questions, reflections, snarky or not. Please, you can put it here. And we will be going through at the very end of this talk a panel discussion going through some of your questions. And so to kick things off, I'm going to get us started really discussing AI in emergency care and discussing the current landscape that we're seeing here. My name is Gabrielle Bunny. I am an Innovation and Design Fellow at Stanford. And I've become very passionate about the work in AI in emergency care and really how we can translate things from desktop to bedside. And so when we start to think about artificial intelligence, the real question is what can AI do? So it can predict. It's trying to predict the future. It can interact with written text. It can read. It can summarize. It can look at pictures. It can take in a lot of visual data. It can output a lot of visual data. And it also can listen as we start to think about ambient technologies. And so for each of these specific categories, what does that mean and translate into for emergency medicine specifically? Well, for predictions, we can see that it's predicting sepsis, as everybody, I think, really loves a good sepsis model popping up on their EHR screen. It can actually start to predict early mortality, right? Trying to predict the course of our patients and their trajectory through their emergency department stay, or even after their emergency department stay. Or even outside of the clinical realm, it can even start to predict things like patients coming back to the emergency department. And so these predictions are all kind of a big part and a big basis of what I think a lot of people really think of for AI and emergency care. But outside of that, we can see that AI for written records is also becoming more and more popular. We're seeing it as the summarization of electronic health records. We're even trying to combine this with prediction, so using natural language processing to predict patient disposition. And we're even looking at it for very specific cases, like using it for identifying symptoms for patients receiving radiation. So it doesn't just have to be for the entire emergency medicine population, but can be for very specific ones and for specific patients that we're taking care of. Next, in vision, we can see computer vision is starting to be able to watch some of our patients. This is an example from the ICU, but we have been approached for ways in which we can monitor our patients while they're boarding in the emergency department, seeing if they're getting up, they're moving, being able to detect whether or not they're going to be a fall risk. And then another classic example is for radiology. How can we be able to get radiology reads and reports turned over faster and potentially have more accurate reads? Finally, for listening, I think this is probably one of the most popular ones that have come up in late, in the ambient artificial intelligence for scribing to reduce the burden of clinical documentation. I think that many companies, both small and large, have been trying to build some of these technologies, and more will be coming down the pipeline. And so for all of this, I just showed you a number of papers, and there are plenty more out there for you to be able to read and see the applications of AI within emergency care. But where do all of these papers and all of these model developments really leave us? Leaves us, frankly, in one of two places. One, a graveyard of models that are predicting something and don't necessarily go beyond the paper that was written about them. Because deployment can be, as someone pointed out, deployment chaos, and it can be very difficult to deploy these models into clinical care. On the other hand, we're off to the races, and they're getting deployed very quickly, and really gives us a chance to think critically about how we consider deployment, how are we rigorously studying the safety and the efficacies of these models in clinical care. And where we're really seeing success, though, in deployment is when we see humans working with AI, this form of augmented intelligence where we can interact and intersect with the AI to either help us do some menial tasks or even help us broaden the way in which we're thinking using a huge corpus of data that we, I think, probably all read at one point, but maybe don't always have access to in the back of our minds. And so considering the core questions to address how humans work with AI, my colleagues are going to really dive into some of the key aspects of how we can work with AI. So first, how do we adapt to technologies, and what are the implications for our identities as physicians? What are the limits of AI in emergency care and the ethical implications of its use? And finally, how do we train future generations of physicians to incorporate AI in their work? And with that, I will pass it off to Dr. Bahara.
Thank you. Hi, everyone. Good afternoon. Wow, I can't see over this. I'm Kamna Balhara. I'm one of the APDs at Hopkins, and I'm also the co-director of our Health Humanities at Hopkins EM initiative. And I'm really here to take a step into the past with everyone. So before we can really look to the future of what AI could mean for our clinical practice, we think it's really important to sort of take a step back in time and consider the broader context around how physicians have traditionally responded to new technologies that have been introduced historically. AI is certainly the technology of the day, the hot buzzword, a growing and leading edge in medicine. But the fact of the matter is that we've been here before as a profession. Patients and doctors have always interacted through the medium of objects and technology, and that relationship has always been nuanced. So in much the same way that there's debate raging around how AI might revolutionize care, antagonize clinicians, or marginalize certain populations, similar debates raged 50, 100, 200 years ago about technologies that were once seen as new but are now commonplace. Let's take the stethoscope, for example. We would never consider it a new technology, but the fact of the matter is in the 1800s, it was totally brand new and exciting. Both due to sort of the moral considerations about how improper it was to touch a stranger's body, and because we had no tools for really looking into the body, the physical exam really wasn't a thing. until about the 17th or 18th century. It wasn't a big part of the patient-physician interaction. But the stethoscope changed all of that. So in the 1800s, when René Laennec comes up with his rolled-up tube stethoscope, now you can listen to the heart sounds without having to, God forbid, touch the patient. And so this really ushers in this new era where the physical exam gains importance and revolutionizes care into what, the model that we kind of see today. But there's no new technology without controversy, right? So at the same time, there's a school of physicians who really like to just put their ear against the patient's chest, and that's how they auscultate heart sounds, and they're all upset because the stethoscope is now going to introduce distance between the patient and the physician. And all of a sudden now the physician can hear something that the patient can't. So there's also this other concern about an element of distancing between the patient and the physician in that relationship. Another technology, anyone know what this is? Yep, that's Alexander Bell's telephone. So I don't think anyone in this room is looking at this and being like, whoa, what a cool and controversial and new technology. But even the telephone was the subject of great controversy in medicine. So in its early days, there was a lot of debate around the telephone in medical journals, the same way that there's debate going on around AI in medical journals. So for instance, in November 1879, there was a case report in the Lancet about how this caregiver was concerned about their kid's cough. So they used their handy dandy telephone, called their physician. The physician listened to the kid's cough on the phone and said, "You're good, we can all go back to bed, this is not croup." And the physician was right. And so people were so excited that all of a sudden you could make a diagnosis or have a conversation with your patient over the phone. And people even imagined, there was another editorial in the Lancet that talked about how we're going to be practicing telephone medicine. There's going to be a group of doctors sitting at the center of a bunch of different wires and auscultating over the phone. And so a lot of excitement around the promise of the telephone. But others worried that the telephone would dehumanize the doctor and patient relationship. That doctors now had to be tethered 24/7 to their phones. They were always accessible. They were like, people can reach us all the time. And does that sort of cheapen our value as physicians? Others were worried, if I'm not actually seeing the patient and touching the patient, then what does it even mean to be a doctor? So the telephone really was sort of a existential crisis for physicians. One guy in 1913 was so mad about the telephone that he actually wrote a poem about it. Where he starts, if you can't see it, it says, "Tinkle, tinkle, little bell, how I wish you safe in hell." And the California State Journal of Medicine published this. So there was all this concern about encroachment on the physician's personal time, misdiagnosis over the telephone, potentially wasted resources over these telephone calls. And there was also a new legal implication. Culpability by neglect of telephone was actually seen as grounds for medical malpractice. So we're having all this dialogue today about AI and best practices around AI. And I just want to share that in 1954, the AMA published best practices around how physicians should use the telephone. But it's something that we would not think twice about today. And this sort of historical context, I think, is really valuable when we're thinking about the technologies that we're concerned about or debating today. We've definitely been in this position before. But history also warns us of the ways in which technology can fail. New technology creates new demands on clinicians' time and resources, generating possibilities for burnout and job dissatisfaction. New technology can also be a force for marginalization. So even though the telephone, for instance, made the doctor available 24/7, the doctor was only available to certain patients 24/7, typically white middle-class families who could afford a telephone. We saw the same thing with telehealth at the start of the pandemic, right? Telehealth was supposed to be the solution for community practices. But the people that didn't have access to the internet, the people usually in a different socioeconomic stratum, weren't getting access to telehealth. So even though there was this idea of democratizing access, you were marginalizing certain populations. And there's similar concerns around AI today. How will potentially biased algorithms derived from skewed data impact those who are underrepresented in those data sets? Thinking also about surveillance and privacy, Dr. Rose will get into some of those concerns as well, but we've even had concerns with medical surveillance and privacy when you think about the speculum, which was deployed selectively with, for instance, Irish immigrants or sex workers who were of different nationalities, specifically to surveil them as a form of medical policing. So we've sort of had a lot of these conversations over hundreds of years over the evolution of medicine. But We don't need to look too far back in time to find an example of a new technology being rolled out and creating a lot of consternation and controversy. So we've got the EHR. So down here is a system called the Promise, which is like a super optimistic name, but it was one of the first EHRs that was rolled out. Up there is IBM's. This thing up here was IBM's iteration of electronic patient records back in the 60s, and people were really excited. So one hospital administrator said, wow, we can get rid of all this clerical work, all this note-taking, all this stuff that takes up so much of our time. The EHR is gonna allow us to spend more time with patients. Spoiler alert, that's not true. So in the years to come, the EHR has become a total flashpoint for controversy and conflict, with concerns that it has failed to live up to its promise. Like the telephone back in the day, it's courted controversy, with physicians complaining about disruption of the patient-physician relationship, impact on job satisfaction, impact on the meaning of what it means to be a physician. I did a narrative review on every article physicians had written about the EHR in the perspective sections of New England Journal and JAMA, and oh my gosh, we have complained a lot. But a lot of the concern appears to be around, what does the EHR mean for our identity as physicians? You know, when you're responding to checkboxes and automated shortcuts and templates that are designed more for billing than for patient care, physicians found themselves questioning, how can I tell this patient's story? Like, how can I actually tell this individual patient's story through time? And then with the glut of data, irrelevant data that you get with copy forward and shortcuts and copy pasting, which I'm sure we all don't do, you know, you get all this irrelevant data. How are you supposed to mine out the data that's important? So there's a real sense in a lot of these articles that physicians' identity as historians, as storytellers, as diagnosticians is being challenged. Some people have sort of risen to the challenge and said, okay, how about I repurpose the EHR to sort of reframe my identity and continue to find satisfaction in what I do? You know, patients now have access to reading our notes, right? That only exists because of the EHR. So people are repurposing the EHR as a way for the patient and the physician to tell the story of their care together. Think about something as simple as screen sharing, right? You can pull up your screen with a patient and look at the results together, or look at an x-ray together with them. That's something that's made possible by the EHR and kind of co-opts the patient as a partner in the diagnostic process. So there's the sort of reframing of the physician identity that's happening in response to the EHR. But again, there's similar sort of controversial discussions and a sense of sort of existential threat being posed around AI and clinicians. There was an article that just came out in the BMJ either this year or last where they literally use the words existential threat. So the question then becomes is, does it really have to be an us versus the technology sort of situation? Because we've got an opportunity to do it over. The potential promise and benefits of the EHR did not materialize and got sort of eclipsed by the ways in which the EHR may have gone astray. But rather than viewing AI as a threat to physician identity, how do we repurpose this relationship into something more that's more symbiotic or more collaborative? So we've talked about how new technologies in the past have revolutionized care, antagonized clinicians, and minoritized certain populations. But we're at this really pivotal moment as AI is growing for us to actually step in as stakeholders in the process and think about how we can reimagine and refocus our practice on the patient with the use of artificial intelligence. In this JAMA article, Abraham Verghese argues that humanism must balance AI, that the computer and physician need to work hand in hand. So in what ways can AI live up to this in ways that EHR failed to? You know, for instance, can AI be leveraged as a way to put the patient front and center of our work again? Can we relegate the painful parts of the EHR, right? Like documenting a certain way so that you can bill a certain way. Can that be AI's problem and not our problem? Think about how much time we spend doing a chart biopsy before going into a patient's room, going through those masses of data. Is that something that natural language processing or AI can sort of generate a relevant summary for us so we can actually spend more time getting data from the patient themselves? And so focus more on the patient by sort of leveraging this work through AI. I think this will probably come up as we discuss this, but we need to be there from the ground up. The EHR grew and ballooned and came to serve a different purpose, which was administrative and billing related. But I think we are at a really pivotal point where if the focus of AI and how we use it is upon the patient, I think we have a chance to do things differently this time around. How do we not let AI get co-opted for purposes other than simply improving patient care? And how do we consider patient needs? How do we remember to bring in the voice of the patient when we're considering how to use AI? And then broadly thinking about the social, public health, and even the environmental and climate impacts of AI, I think are going to be crucial to us if we're trying to frame ourselves as stewards of this technology. Despite the very real promise to enhance healthcare, there's of course real threats also posed by AI or irresponsible use of AI. So now I'm going to turn it over to Dr. Rose to get into the gloom and doom.
All right. Thank you so much, Dr. Baller. Oh, man. I feel like that just kind of needs a mic drop straight up off the bat. Also, you'll notice the QR code in the bottom right. That's for people to share any thoughts that come up today as people are talking. Really, we want to hear from you guys because this is really about what we're hoping to get to. So far, the only comment is the left-handed robot human handshake makes me uncomfortable. I feel like there's more than that out in the audience. It's entirely possible that speaks for everyone, and it's okay if that's the way it is. I think that perspective of where we can go to and what we need to do right now is extremely crucial at this point in time. I think obviously we'd be remiss if we don't discuss some of the detriments that this technology represents, which I was happy to see in the initial Padlet, lots of people bringing up the issues of bias and how these systems can potentially negatively affect patients and exacerbate disparities. So, let's see. Has anybody seen this picture before? This is from literally 2 weeks ago in San Francisco, where I live, at Kaiser San Francisco, where I have worked in the ED before. And it's a nursing strike about not trusting AI to do nurses' jobs, and lots of physicians I knew felt similarly as well. There's a lot to unpack here. I think it's pretty impressive to see that we've already come to this place in the paradigm already. And I want to sort of jump right into what's going on there. I think the first issue might be job security concerns. When thinking about the future of AI in medical care and emergency care, it is very easy to try to envision all of the ways in which this technology can do these human things, whether it can read ECGs, read CT scans, talk to patients, respond to inbox messages. We think of all the things we can do and we go, oh my God, the computer can do it even better than me, or not much worse than me. And I don't think that that's necessarily the wrong way to go about it, especially for an academic crew like this, but I do think it lacks a little bit of the imagination of instead using this technology to augment and to really say, what do I want to do as a provider, and how do I get there with these technologies? Of course, that comes with a lot of risks, and I'm going to give you a little bit of a framework now for me, I think from the data through to the end workflow. So if you start with the risks to privacy and data security, I'm sure people have seen some of the articles in that training GPT meant just taking a lot of licensed information from the internet, movies, creating individual images from every slide in a movie, taking books you've read, newspaper articles. The New York Times is suing OpenAI. Other, I think the Wall Street Journal is involved now too. Essentially, the cat's out of the bag, and everything that existed online has been used to train these models. And as we think about medical models, we of course think about specific patient populations and who's involved in the data sets, but we've been pretty good and careful about that in the past. Unfortunately, once this happens, there's sort of no way to disentangle the way the model works with some of the private information that it was created upon. And separating those two becomes extremely difficult, and is something that a lot of policy workers that are much smarter than I are working on. Essentially, we even wonder whether privacy and anonymity is possible in the AI future, because you can back engineer finding out exactly who someone is from very specific criteria that are encoded in the data. If you take that then and say, well, what about these potential biases for how we make recommendations and who gets what? Will the rich get richer and the poor get poorer, and only people who have access to these technologies see and reap the results? I think there's a question to be said of whether any of this actually even moves the needle for a lot of care. But at the same time, the data that we have in the past, I don't think a lot of people in this room think that all of the medical data up until 2024 is like very representational, and most of the places making models right now might not represent the entirety of the country, as even evidenced by like the EPIC sepsis model, which came up before. It's pretty much fails across the board when put into unique patient populations, and now we're trying to struggle with how to think about that. So there's definitely an issue of how we treated people in the past and how that trains models and how it might affect our care in the future. Because of that, you say like, okay, well, what if I wanted to just address that and look and say like, why is this model doing what it's doing? You can do that. There's a lot of talk around explainable AI and trying to get better at understanding how, in theory, black box models work. People in this room who I know are working on some of these problems and are doing a great job, because we as physicians do tons of things we don't know how they work. Barely know how ketamine works. We use it all the time. But we do want to be able to ask and to go and dive a little bit deeper. We don't usually just take things at a superficial level. To that point, so say I use a model, say I'm using GPT at the bedside and it gives a recommendation to a patient. You can take a utilitarian approach and say, oh, this is in the good of access to the many, and mistakes are going to happen just like humans, but that's the risk we're willing to pay for greater access or timeliness of care. But we have no real idea who ultimately foots that responsibility. I think there's a great argument to be had that the physician usually represents the face of all of medical care, and when it works well, we're not necessarily appreciated as much as we could, and when it fails, we usually have to be the person to tell patients, I'm sorry, something bad happened. It's not usually the model having to go, oh, sorry, let me talk to Microsoft and we'll get back to you later. The other one, which Dr. Ballar spoke about, so we won't spend too much time, is really workflow disruptions. When things get into practice, we're all for I want it to do A, B, and C, but in the history of technological innovation, in the history of science, when people present new technologies, it doesn't usually wholesale wipe out a job. It usually changes the nature of that job and what it means for both sides, patients and how they engage with healthcare, but also us and what we do as physicians. To that point, I think there's some very clear examples, which can't get out of the news recently, but times where we use artificial intelligence systems to try to protect us from human flaws. And then when something really bad happens, like any patient you see in the emergency department, all of a sudden we don't know what to do and we can't override the system, and it's a terrible disaster. So we have to be very careful about over-reliance on AI. That is bandied about a lot, but really we deal with emergency care, so we have to be very careful of how we use this. Ultimately, all that is to say that when we're playing Pandora, there's a ton of potential benefit, and obviously we'd be remiss without discussing these pitfalls, but they're going to change in the landscape, and part of that has to do with how we frame this technology and how we make it work for us in a way that's authentic, safe, and equitable for everyone. I'll kick it over for Dr. Praschaitis.
All right, thank you, Dr. Rose. my name's Carl Praschaitis. I'm gonna give a little bit of a brief overview of some ideas I think about in terms of AI in education. There's a lot that we still need to discover, but hopefully these are some ideas and some things that you can start to think about, and we'll get into some discussion here shortly. The first part I want to discuss is what's been called developing some sort of AI literacy. And if you look into the literature, this typically includes understanding the capabilities of AI, integrating AI into clinical practice, and then ensuring some sort of responsible use of AI. I think what isn't exactly clear is to what degree being AI literate requires a technical understanding of the models. So one of the things is that AI functions very differently than a lot of technologies we're used to interfacing with. So people that are technologically savvy or digitally native, they might not out of the box be able to use these models effectively. So we need specific paradigms to develop how we train physicians or other people how to use these models effectively. And the other thing is how much you really need to understand how AI works. I study a lot about AI, and a lot of discussions are about technical implications of the models, like how transformer model architecture functions. And it's not really clear how much of a technical understanding you need to have to be able to use these technologies safely and effectively. And I think we need to scope what that depth of knowledge is before we go off and start designing curricula that are going to train people how to use AI effectively. The next point is about navigating black boxes. So I think we've heard this idea of AI being a black box model where we don't really understand how it comes up with a specific output. I think what we can do as educators is to start re-emphasizing the importance of understanding how to work with black boxes. And I think thinking about AI, we start to understand that there are a number of black boxes we encounter in the clinical environment all the time. That are very analogous. Like if you get a recommendation from a consultant, you don't know specifically the line of reasoning that they're going through and where they got that information and whether it's factually accurate from their training. You can ask them, but oftentimes we take a lot of these recommendations at their word. Like Christian said, like you might not know the pharmacokinetics of every medication that you prescribe, but that doesn't necessarily prevent you from understanding how to use them safely and effectively. So I think re-emphasizing that a lot of the data we encounter in the clinical environment is in some ways unknowable how we arrive to those answers, and then teaching people how do we critically evaluate some of that data when there's uncertainty around it, and how do we use it effectively. One way that I think we can start to think about it is I think us as scientists, we tend to take a very positivist approach to data uncertainty. We want to know whether something's correct or incorrect, but we can start operating a little bit more pragmatically and saying like, whether this data is incorrect or correct, we want to know how is it effective, is it useful in this situation, and context really matters. There's a lot of things that we do in medicine that are predicated on best available evidence, and we take in the information in the clinical scenario and then make judgment calls. So when we're training individuals, whether they're medical students or residents, how do we train them how to take in the context of where they're operationalizing that data and understand whether the data that they have is going to be good enough and useful for making clinical decisions. None of these things is really plays out in isolation. As a lot of like the papers on AI, they're very focused on just training the efficacy of the model and how the outputs are. But really we want to understand how do people use these models, how do they work with them, and what are the ultimate downstream effects of if you work with AI, what clinical decisions are made. We're not abdicating that AI is going to make all the clinical decisions. We're going to take in information and then make our own decisions. So we really need to understand how effective is this model when humans actually work with it. A related issue is understanding a little bit more about this human-AI interaction. Part of understanding what situations AI is going to be effective in helping physicians is understanding how, as AI becomes more ubiquitous, how does the nature of our work change? What are the tasks that we really want to be focused on doing with our patients? What are the things that we don't mind letting go of and letting AI take the reins on? But then not completely abandoning doing any analysis and starting to look like, once we incorporate AI, how does our work continually change? How does this affect how we communicate with patients? How does it affect their experience in the emergency department? How does it affect how we communicate with other team members? And we don't have a lot of good frameworks currently for how to think about that from a research perspective, but we need to develop those. We know the electronic health record had this profound impact on practice, but we really only realized the impact like 10, 15, 20 years down the line when we saw how horrible everything had become. So we need some more adaptable frameworks. So as we roll out some of these technologies, we can start looking at how is it changing our nature of practice. And then the last point I want to make is sort of as a corollary to understanding how AI impacts us as humans, AI is likely going to cause a shift in the skills that we value as physicians. And training programs, I think, need to be very responsive to those changes to ensure that we continue to train physicians that can bring as much value as possible to the clinical environment. Training for AI literacy is going to be part of that. So will emphasis on evaluating information that comes from black boxes. And if you think about sort of the historical context, these shifts have always been apparent, like the de-emphasis of memorization of knowledge because we can rapidly have knowledge at our fingertips. So that's going to change. It's just not exactly clear how quickly that's going to happen and specifically what tasks we're going to need to focus on. As an aside about that as well, like we need to start re-envisioning how we're assessing physicians. Once we determine those competencies, starting to think about new ways of assessing physicians. You know, I think we're all aware of some of the performances of these models on standardized tests like the USMLE, and I think it says a lot less about the capabilities of the model and says a lot more about the quality of those examinations, and saying the knowledge that we're assessing in those examinations is really limited. So reconsidering what type of knowledge we want physicians to have, what skills we want them to have, and then ensuring that we're training them effectively to meet sort of those requirements. So this is our QR code again. We're going to transition now to a panel discussion. We'll see if there are any questions that came from the audience. We also have some prepared questions Christian's going to moderate, but let's talk about this.
I will become the voice of the audience. I am your conduit to the GPT that is these amazingly intelligent and awesome forward-thinking panelists. So before jumping into some of our questions, there's some online, but is there anything that jumps to mind when thinking about how, you know, emergency physicians can actualize better care through this? What are you guys thinking about? Any questions come up off the bat? Yeah.
Quick question.
Sure.
Toby Efron, I work at Mount Sinai in Chicago.
Nice to meet you,
I also
Toby.
work for Beckman Coulter. We're here at commercial as well. But, you know, just thinking about this, what is the and I don't want to say low bar, but I'm going to say, what is the low bar for adoption? Like, we talked a little bit about transparency and that sort of thing. You know, is it sort of specificity? Like, what is it that physicians, and myself included, need to know to understand how these models function and how they perform? Like, what are the specifications?
Yeah. I think that question goes really well on one of the things we wanted to talk about, which is how are we going to know, like, if they're working, if there's an ROI, what is the MVP, the minimal viable product of, like, these things working? I think I would flip that to the panel in terms of, like, what is working? How are we going to know that these are doing anything positive for us? I feel like there's many different ways to interpret that.
Hello. Oh, okay. So I think that really stems back from what we want it to, what it is we're asking it to do. If we're asking it to do some administrative tasks, I think we can see whether or not it's improving the return on investment for what we had to put into getting this model to work. But that's purely from an administrative side. I think when we start thinking about how we're putting it into clinical care, I think it comes back to rigorous clinical testing, right? This technology really shouldn't be any different than anything else we've implemented in healthcare, right? We should be checking that it's, working either at the same or better than what we're doing in current clinical practice, that it's doing so equitably, and performing these trials, whether or not we're doing, initially doing it retrospectively, which is what everybody has already started to do, but then how can we see how it's working prospectively? Do we do it in the form of silent pilots going forward, seeing how it's working in the clinical environment compared to what we're doing as clinicians, and then when we finally turned on, continuing to study it from there. I think there's been a lot of discussion of how do we best implement these models? And I think what's interesting is that in a lot of ways, I think we're trying to think about it as some unique and very different special piece of technology when, it's just another clinical tool and we should be treating it and studying it as such.
Yeah, I think the other part to consider is when we think about like clinical performance, and we're talking about like physicians using AI in concert in the clinical environment, we actually don't really have a lot of metrics for measuring clinical performance. You can do some gross things like what's done for a lot of these models, like whether somebody's admitted or they're discharged, whether they die or not, whether they're admitted to the ICU. But when you start getting into some of the more nuances about how do you interact with patients, like how do you know if you're ordering the most effective tests at the most efficient time, like we really need some better metrics and better ways of measuring sort of AI in concert with physicians. And I think right now, what the problem is a lot of the literature that's being published it sort of focuses on diagnostics or predicting whether somebody's going to get admitted or not. And we all know in practice, like, you can know the diagnosis, but if the CT scanner is not working, or if you can't get the consultant on the phone, or any number of other operational issues, that's very challenging and really burdensome in our job. Diagnosis is really not something that I think a lot of us struggle with. For most cases, like most emergency medicine diagnostics we're experts at doing that. So really the focus should turn away from those type of outcomes and more on what are the things that we can do to further optimize our care and where are the pain points. But we need good measures to decide whether it's working or not in those situations.
If I might just add one more thing. I think, I know we're talking about what elements a model would need to have or certain outcomes it would need to meet in order to be scaled up or implemented. I still feel like from, being an educator, from an education perspective, we are so far behind preparing our residents and current clinicians in practice to be able to work with it. Like, I don't know how we'd be able to move forward with widespread implementation if we don't have formal training structures in place. The same way that we're not going to set someone loose with some sort of new technology or a new procedural kit without doing rigorous training ahead of time. I don't even think that we're necessarily there yet. And for me, that's a huge sort of stepping stone that we haven't got to.
Sorry, just a follow-up. What would be sort of minimal elements that somebody would have to understand? Like, for me, myself, I would like to know the features that go into, whatever output comes out. I feel like that's easy enough for us as clinicians to understand. Do you think you need to understand how the model works, like what flavor of model it is, that sort of thing?
Yeah, in my mind, I think the conversation that we're having here in terms of legal implications, right? Like liability, if you're going with the decision recommended by a model, who's liable? Ethical implications around it. Like, we're not necessarily having those conversations around how to operationalize it in clinical practice and sort of the sticky points that we're going to get into. I don't have any head for this at all, so I probably wouldn't understand how models were derived, and I'm not sure that would be of value. But in the same way that we teach people best practices in documentation, right? We have learner milestones that evaluate whether or not someone is consistently using the electronic health record appropriately. Like, we don't have that framework set up yet, and I think with the EHR, we sort of put the cart before the horse and caught up afterwards. And I don't know if this is a time for those who are involved in the science to be working with those who are involved in education to think about all these other nuanced elements that are going to make it hard to put into practice.
I think that's a great response. I'll follow up on it. I'm not sure which of you two had your hand up first. I'll go here and then over there. But I think one of the important distinctions too right now, and something changed clearly in the last couple of years, right? And we're all struggling to say, like, is it making healthcare better? I think we lack a lot of clarity in terms of what parts we want better. I have this discussion a lot, and I know that from like an investor side, people want to say, like, what is return on this investment? What is improving? Sometimes that's access for people that don't have access to a doctor, of which there are many in the United States and abroad. Any ability to chat with anything is really good, and that has a health equity bend to it, and that is important for some people and grant funding organizations. Is it more consistent care and bundled care, making sure everything is ordered that should be in a sepsis package because people forget and humans are fallible? That could be like the MVP for some models, but these are also, we've shifted into the general model frame where it can do many things. We're wondering all the ways it can do stuff, and yet we haven't really reflected back on, okay, what parts of care are we hoping to, what is the problem we wanted to address, and do we have a good way of measuring improvement on that process?
I think to that end, my name is Brad Gordon from Regis Hospital, St. Paul, Minnesota. I think we're still at this point where there's these use cases and the metrics linked to the use case and calling the whole package AI, just like you had mentioned, under training people to use it, but that's exactly what we do with voice recognition. We basically say, hey, you can log in, and yeah, maybe you should do the training profile, but most people don't, and they just start using it, and they probably should be trained to at least look at the text that comes out, but often they choose not to, and they learn to put a statement that may have been generated by somebody else, and is good enough apparently. To my end there is, I think I like the analogies to to like medication, and like, I don't know how a procalcitonin works, and I kind of know how to use it in clinical practice, but I never had to be trained on it, although I probably was trained at some point. And I'm wondering how, almost like we need in emergency medicine and any part of it, like a list of the use cases that we're considering these large language models for, or other things to help build the metrics against them, whether it's the patient instruction rewriter in the proper tone that I don't have time to do, or it's the chart summarizer, or, you know, in the same ways that most of the time these have ended up in some type of new name beyond AI once they've got a specific use case, like self-driving car out on the street today. So we don't call it AI, there's an AI driving by, we call it, oh, there's a Waymo, or there's a thing, or the triage go from our plenary session.
I'm probably mistaken. That seemed like a really great comment, of which I agree with most of it. Was there a specific question to the panel?
What I'm wondering is there, thank you.
I agree.
Boy, that was a great second grade comment. Is there any work to build that list of registries and more actionable steps in our specialty at this point versus sort of tilting at the bigger picture of AI is coming? That's my question. Thank you.
Yeah, no.
I mean, I don't think so. Not that, I mean, I'm not aware of anybody working on like use cases, like what should we really be focusing on? I think part of what we're trying to do is inspire more people to get engaged in this space and say like, what are the use cases that we should be working on? Because you look at stuff that's published, and like the people that are publishing these things about diagnoses, there are no physicians that are authoring these papers, and they don't know what we need. So I think, you know, now's the time for us to start getting together, forming like these coalitions and saying, what are the use cases we really want to see? And, you know, how can we think about managing metrics to determine whether we're there? And I think, you know, this is probably a problem in a larger scope of a lot of quality improvement work that happens in medicine, like, you know, Dragon software, new technology. A lot of those things get implemented because they seem like a good idea without an idea of like, what's the metric? How do we know this is going to be better for physicians or patients? And that's kind of the EHR was a great example of that. But it happens all the time where we're like, we're going to do this new process flow, but we don't really have a good metric to know whether it's going to be better or not. We'll just look at like some overall like score that is made of an amalgam of things. So I think really focusing on like, if we're going to come up with these use cases, how do we know whether it's going to be better, and then we can actually measure it.
Yeah, I think alongside of that is also making sure we're answering the right question. To some degree, I think we're doing this a little bit backwards. We have this piece of technology and we're like, where does it fit? We got to put it in somewhere, rather than actually looking for the clinical problem and what's the right tool to actually solve that problem. And sometimes it isn't necessarily AI. And I see a comment on here looking at, you know, black box or deep learning models being better than logistic regression. And, you know, we see neural networks and things like that being great for, you know, large, you know, areas of data. But logistic regression can still be the appropriate model to solve the right clinical question. And so going into, you know, not only the correct metrics, but actually solving the right problems, rather than, you know, a lot of, I think even our talk is, you know, using AI in emergency medicine, and I think that's really how we've all been thinking about it, because we're all so you know, excited about it. But is it even the right thing to be using for this for any given use case that you're thinking about using it for?
Question, do you still have your question in the blue shirt?
Yes,
Yeah.
related to what we was talking about in terms of there's, like, Epic is supposedly coming out with, like, you write your note, you discuss what you discuss with the patient, and it will generate your discharge notes based upon that. There's also, like, ambient AI that will write a good portion of the note. Presumably you can go through and modify aspects of the ROS and the history to get to that. Has there been any active discussion you're aware of on AI that analyzes across patient cases regarding how providers provide care to people of different subgroups and making them more aware of possible inequities in their care to advance the care they deliver?
Sure. I can take a stab at part of that. There's been really great research, published research on scanning the notes for unmet social determinants of health needs, which I think we know lots of providers are not great about, but you might have actually discussed a topic, then not done nothing about it. And some of these technologies, again, I think we've talked a lot about as a group was reflecting back and saying, like, not only can this, like, a lot of focus is on how can this technology do all the things that I can do better, but not much has been reflecting back on, like, am I being the best human doctor that I can be? And I think that's one of the good use cases where you are writing, doing, providing care, and then you find out before discharge, like, you know, you talked about blank or you didn't talk about blank. Did you want to ask? You don't have to ask, like, but you didn't talk about this person's, like, food, you know, or housing safety and security, or you didn't ask certain questions. That could, of course, run away, but there has been good work recently to basically scan the charts and be able to feed back to people whether or not they're doing some of those things to provide better care. There was the person in the back there, and then Dr. Brown.
So, kind of related to a previous question, and one of the topics you talked about in terms of the metrics, do we have to create new metrics? We have a whole bunch of core competencies, we've got a whole bunch of initiatives that are set forth by our own specialty and by healthcare. Can't we just, you know, to the point of the procalcitonin, like, you know, let's make sure that it's safe, right? We should do our due diligence, but can't we just use those as an opportunity to decide whether it works for us? Can we help our residents achieve additional competency in systems-based practice, right? You know, evaluating social determinants of health, doing those things that we want them to do, but we're really bad at doing them.
Yeah.
Do you see that as an opportunity, or do you think we really have to create new metrics?
I'm going to intentionally be I'm rubber and you're glue and flip it off to my, like, actual educator. But in my head, the first thing that comes to mind is the meme of, like, oh, we have too many standards. We need this one that don't represent what we need. We need a better standard, and then you just have one more new standard and measure. I will flip that over to the people who think a lot more about these things for me. Do you think we can get by with what we have, or do we really need new measurements?
I don't think from an educator's perspective, I don't think that we necessarily need new measurements, but we need to modify the existing measurements to reflect the current landscape of clinical decision-making and the tools that are available to us. So when you talk about systems-based practice, I think there's elements there like, are you engaging, is a learner engaging with social work? Are they taking into account the patient's payer model, et cetera, right? Like those elements need to be modified to reflect the sources of information that are out there. And I think one other thing, I'm going off on my personal soapbox, I'll just say, is one thing that defines our job is uncertainty. And I think that's what the magic of AI is for many people, is providing certainty in a very nuanced job. And I don't think as educators or in our educational metrics that we think about how do we talk about uncertainty and how do we talk about these different tools and how they loop back to that concept of uncertainty. So I think that there is room for growth and improvement in how we talk about these things with our learners.
I think we're coming towards the end. I'll go to Dr. Brown.
Would you have permission to try to respond to a previous question?
Sure, yeah.
You asked about, you put forward some epic-specific tools for looking at AI in the patient, and then you took it up a level to say, what does Epic have for looking across encounters at a hospital system or national level? I was on the some of the founding members of the ASAP Advisory Committee at Epic, and there's a new tool that came out recently called Cosmos, and I think that is part of what the idea behind this tool, which is to look at how care is delivered across different systems and try to take a larger view. And it has a lot of tools around social determinants of health and lets you look at anonymous, mostly data from different hospitals and do that kind of evaluation. So it's a new tool. It's what it's made for, and it's just being released at all down hospitals, so you can see more of it.
All right, any last questions before we, I think we're right at our time. All right, otherwise, feel free to email any of us. Obviously, hopefully this was an engaging discussion and spurred some ideas, and hopefully you guys all go out and change the future. Thank you so much to our awesome panelists and experts up here. We'll be up here for questions as well.